Good morning everyone, my name is Arik and I am an intern at Meir Medical Center in Kfar Saba. Today I'll be presenting the case of an idiopathic Frosted Branch Angiitis. The case involves a 43-year-old male patient with controlled hypertension and no prior ocular history. He presented to our ER with a complaint of a central floating scotoma in his left eye since waking up that morning. Additionally, he reported a decreased visual acuity in the left eye and pain in his left eye and eyelid. The patient's visual acuity in his left eye was limited to hand motion, and upon examination he exhibited a positive REPD in that eye. Examination of the right eye was completely normal. His left eye showed moderate upper eyelid edema of the follicles and petechia. The conjunctiva was hyperemic and there was significant anterior chamber activity with +3 cells. Notably, the retinal vessels appeared dilated with perivascular sheathing. There was also a periretinal hemorrhage and dot hemorrhages in all 4 quadrants. The optic disc margins were blurred with peripapillary flame hemorrhages and cotton wool spots. Fluorescein angiography of the left eye revealed retinal hemorrhages, thick and leaky vessels, and diffused vasculitis. The clinical appearance of his retina raised suspicion for Frosted Branch Angiitis, and the patient was admitted for further workup. During admission, extensive testing was performed, including an anterior chamber tap of his left eye, which was negative for herpes viruses, CMV, and toxoplasma. All other tests were normal except for an ice level at the upper edge of the normal range. Now let's discuss Frosted Branch Angiitis. This is a unique form of uveitis and retinal vasculitis. It was first described in 1976 in a 6-year-old Japanese boy who developed idiopathic bilateral panuveitis and retinal vasculitis. The condition is named for the thick sheathing around the retinal veins, resembling frosted tree branches in the winter. In the 70s and the 80s, FBA was sporadically reported as a distinct disease or syndrome. However, in the 1990s, cases emerged linking the clinical appearance of FBA to systemic pathologies. In 1997, Dr. Kleiner laid the groundwork for characterizing FBA, classifying 3 groups. Type 1 occurs in relation to lymphoma or leukemia and is caused by cancer cells directly infiltrating blood vessel wall. Type 2, which is the largest group, is considered to be secondary to autoimmune or viral diseases. It is hypothesized that the appearance of the sheathed blood vessels results from the virus infiltrating the blood vessel walls or a hypertensive reaction to this infiltration. Type 3, idiopathic FBA, occurs in healthy young patients and has an unknown pathogenesis. It is hypothesized to be immune-mediated, possibly triggered by viral or bacterial infections. Studies about FBA identified a bimodal age distribution in FBA type 3, with peaks at around 10 years old and 30 years old of age. Frosted Branch Angiitis can lead to complications, such as macular edema and CRVO. CRVO often develops since underlying microvascular issues persist, eventually triggering the coagulation cascade and resulting in thrombosis. While recurrences of FBA are rare, they do occur, with a recurrence rate of 3% for type 2 and 2% for type 3. The period to recurrence can vary widely, ranging from 4 months to 10 years. Back to our patients. While admitted, he was treated with topical steroids. His condition stabilized, the hemorrhages started to absorb, and he was discharged with a treatment regimen of oral prednisone and topical steroids. At post-discharge follow-ups, the patient's visual acuity was getting better and better from hand motion when he first came to us to 620 last week. We gradually reduced the patient's prednisone dose. As time passed, the retinal hemorrhages gradually absorbed, VMT developed, and subsequently improved. Also, ERM has developed. On his last follow-up, the patient mainly complained about floaters and metamorphopsias. As you can see in his last follow-up, there are telangiectasis, there are few round retinal hemorrhages, and ERM. And this is a photo for comparison. The case highlights several key points about FBA. FBA is a heterogeneous disease that often develops in the presence of an underlying condition such as CMV, FMF, or Behçet's disease. Idiopathic FBA typically occurs in a younger population, tends to be bilateral, however in our case it was unilateral, and it has a good prognosis. Importantly, patients generally experience rapid improvement following steroid treatment. Thank you.